Okay, so our first afternoon session is going to be with Dr. Kevin Moran. He's a consultant surgeon in Letterkenny University Hospital. He's the Donegal GA team doctor, and this afternoon's talk is titled The Role of the Team Doctor.
Thanks, Ger. Orders Juror Cumann Lucas Gael, distinguished visitors and guests. Following Pat O'Neill is a very tricky assignment. Pat has the amazing distinction, he's one of the most modest people I know, but between 1974 and 1980, Pat caused more concussions than he has cured in the remainder of his career. Every player involved in a contact sport over an extended period of time will inevitably sustain a minor traumatic brain injury. Fortunately, very few of these injuries evolve into a concussion. And as we've said already this morning, the position of the GEA is very clear and unequivocal. If there is any concern for the welfare of a player, they must be removed immediately from the field of play, undergo a medical assessment, and they cannot be returned until they are fully cleared, and that may mean having a period of rehabilitation as per our protocols that's supervised. So, as a member of the medical committee here in Croke Park, and as a team doctor who has diagnosed and treated players at all ages, at club and county level, I'm delighted to have the opportunity to address this conference. Concussion is not just an issue for the medics, however. Everybody has a role to play. Indeed, I'd suggest everybody really needs to be informed about this issue, and this is why this poster is so important. It's up, or it should be up on every dressing room wall in the country, because we want everybody to take ownership of this problem. Players, parents, teachers, coaches, referees, administrators. The challenge, of course, for the doctor is to decide where does concussion actually begin. Traumatic brain injuries are classified according to the Glasgow Coma Scale, which is an internationally recognized classification. It's a little bit arbitrary, into mild, moderate, and severe. If you look at this, you will see that concussion is placed at the mild end of the spectrum, but that can be very misleading because, of course, concussion can evolve into a very serious injury. It can actually be fatal. Just a little bit of background about doctors. Doctors are used to practicing in a very controlled, calm environment. Medical diagnosis, most medical diagnoses are made on the basis of clinical examination, backed up, if necessary, by blood tests, x-rays, and scans. The tension in the dugout and the chaos on the pitch, they're very new experiences for most doctors, and diagnosing concussion is also a different experience for doctors, because often they have to rely on, we've heard a discussion this morning, but they have to rely on clinical judgment and make that judgment and stick by that judgment. Earlier this year, I had the opportunity to visit the University of Pittsburgh and Pittsburgh Steelers and spend some time with Michael Collins, and you can see how expert he is. In fact, it was amazing even last night to continue our dialogue with Anthony and Michael and Anne. As a surgeon, I'm not saying that I agree with everything that psychologists tell me. There would be something wrong with me if I did. But I have to say it's wonderful meeting and watching Mickey Collins, the way he ran his clinic in particular. I learned an enormous amount. Pittsburgh is regarded as the centre of excellence for the diagnosis, rehabilitation, and research into sports-related concussions. But when I was leaving Pittsburgh, I was under no doubt but that the protocols and practices that we have in place here in the GEA compare very favourably with that of any of the major international professional sporting organisations. Many of you will have seen, probably most of you have heard about the film Concussion, which is set in Pittsburgh. It tells the story, or at least purports to tell the story, of the sad ending of a number of Pittsburgh Steelers legends, including the findings at post-mortem. I suppose the major benefit of this film was that it greatly increased public awareness through public discourse. Even when you strip out the Hollywood hyperbole, and there's plenty of that in the film, the question still remains to be answered. What, if anything, is the relationship between chronic traumatic encephalopathy and repeated brain injuries and concussions? The thing that I learned from this film that was most useful was that woodpeckers don't get concussed. That's not just a facetious observation. It actually gives us a great insight into concussion and the human brain. The woodpecker can strike the tree or the bark of the tree 12,000 times a day, generating speeds of up to 15 miles per hour. When the force at impact is measured, the forces can be up to 1,200 G-forces. So let me put that into context for you. If you subject the human body to a G-force of greater than 100, it's likely the concussion will result. If you subject the human body to greater than 1,000 G-forces, then you're talking about a road traffic accident at high velocity on impact or deceleration. So why does a woodpecker not get concussed? Because in the evolutionary scale, the brain fits very snugly within the cranial cavity. The inner table of bone of the cranial cavity has a shock absorption property. The neck and the hyoid bone in the neck are specially adapted, and there's even an extra eyelid. Sadly, the human brain doesn't have any of these protective mechanisms. At surgery or at post-mortem, the human brain is a jelly-like substance. That's why it requires the bony skull for protection. Surrounding the brain is a layer of cerebrospinal fluid, which is a very poor shock absorber. The other aspect about the human brain is that it is very mobile in all directions and all planes, increasing its vulnerability. Concussion occurs when this jelly-like substance is propelled against the hard, bony skull. And this can occur as a result of an impact to the skull, to the torso, or on deceleration. Most often, it's in a linear direction, but because of the mobility of the brain, there may also be a rotational component which causes far more damage. I just want to make just one interesting observation. We heard a little bit about the pathophysiology of concussion this morning, but there is a striking parallel between the concussed brain cell and the fatigued muscle cell before it cramps. They both go through what's called a metabolic crisis. As Mickey showed you this morning, the glucose is used up. There isn't enough oxygen, and lactic acid levels increase. This is actually exactly what happens in the calf muscle before cramping. It used to be taught that concussion was a single entity. Now, as Mickey said this morning on a number of occasions, we know that it's quite different. In fact, every player with a concussion has a unique injury. So to consider concussion as a single entity is obviously inaccurate. It's actually a heterogeneous group of brain injuries. And that means that any part of the brain can be injured, from the higher centers in the cerebral cortex to the diffuse areas that make up the limbic system, to the eyes, to the inner ears, and the brainstem and spinal cord. Consequently, concussions are divided into 6 clinical subgroups or domains. And I won't blind you with science. I'll make this very pictorial. The cognitive domain is the area that separates the human being from other species. It's the one that distinguishes us. And basically, the cerebral cortex is responsible, at its simplest, for processing new information, for storing data in the memory base, and for making decisions. A concussed player will have difficulty concentrating, will be very easily distracted, will be unable to process new information, will have impaired recent memory, and will be unable to make decisions. And they will often describe themselves as being in a fog. The second domain refers to the headache that's almost universal with headaches and concussions. In concussion, the headache has an unusual property in that it can be made worse by bright lights, which is called photophobia, or by loud noises, which is called phonophobia. And as the concussion becomes established, the headache tends to become unilateral and have a throbbing quality, and hence the association with migraine headache. This is a very busy slide, and all it tells you is that human emotions are very, very complicated. But anybody who has treated a concussed player will know just how irritable they are. They're often frequently very anxious, to have a feeling of impending doom that they can't explain. In the most severe cases, their whole thought processes are distorted. And thoughts can then become feelings, which become emotions, which impact on behavior. And this would appear to be the genesis of the anxiety and depression, which is so prevalent in significant cases of concussion. The fourth domain relates to the eyes and to the movement of the eyes. And this is one of the things on my visit to Pittsburgh I found most fascinating, and the amount of research and how far ahead our colleagues who are the gold standard internationally are in this area. The eyes are actually an extension of the brain, and therefore the only part of the brain that can be seen directly or inspected. Since biblical times, the eyes have been regarded as windows to the soul. And in concussion, they have a characteristic appearance. We heard a lot about the movements of the eyes this morning. The eyes require, the movement of each eye is controlled by 6 individual muscles and 3 nerves. And vision is possible because light rays on the retina at the back of the eye are converted into visual images in the ophthalmic cortex at the back of the brain. So it doesn't take a lot of imagination to realize that with these very fine, precise physiological mechanisms, that even minor concussions can cause significant disruption. The fifth domain relates to the problems that concussed players have with balance. Players can do all kinds of extraordinary things. They can run, jump, and perform acrobatic maneuvers that defy gravity because of their sense of balance. And balance, in turn, requires input from 3 sources: from the eyes, from the vestibular apparatus in the inner ear, and from proprioception peripherally from the limbs and joints. In the inner ear, there's a series of 3 semicircular canals. As the name states, they're semicircular. They are canals, they contain fluid, they're at right angles to each other, and they measure rotational movements. And they're one of the things that are affected in the very early stages after a head injury or concussion. The last domain refers to the symptoms that come from the neck, or more accurately, from the spinal cord in the neck and the nerve roots in the neck. And these include headache and pain in the neck, in addition to peripheral symptoms such as pins and needles and numbness. So, if you take all this information, how does the team doctor take this information and all this theory from the comfort and the calm of the office and take that onto the pitch, to the blood and the sweat and the mud? Well, I think you need to have a system to begin with, a system that's accurate, that can be reproduced, and a system that can be used in all pitches and all venues and all times. For example, in my case, that could be in Glenswilly in front of 80 people in the middle of winter, or here in Croke Park with a full house in the middle of summer. I think in the increasingly litigious times we're living in, this system has to be able to withstand the media assessment and a public assessment, and probably also in the future a jurisprudential review. I use a 4-stage process to diagnose or exclude concussion. This involves knowing the player, knowing their history. The second part of this, which is very, very important and which was emphasized by Professor Mick Malloy this morning, is witnessing the collision in real time. The third part of it, which is also very important, is performing a focused examination on the pitch, knowing exactly what you're looking for, knowing how to look for it, and knowing how to interpret what you find. And the final part then is monitoring the player as appropriate subsequently. We now know, of course, that females and underage players get concussed more easily and recover more slowly. In addition, they are also susceptible to second impact syndrome, and I had a fascinating discussion with Mickey and Anthony in particular about this last night, and about what exactly is second impact syndrome. Second impact syndrome is where a player who has been concussed gets a second brain injury before the first one has recovered. It can be quite a mild or quite trivial compared to the first injury. Without warning, the brain becomes swollen, and this process is irreversible and it's inevitably fatal. We don't know a lot about the pathophysiology or why this happens. It would appear to be disruption to the cerebral circulation, that the brain just continues to swell. And there are case reports showing that even when the dome is taken off the skull and the brain is allowed to swell, the process is still fatal. I'm not aware of any such case in the GAA, but there is no room for complacency. Everybody is familiar with the sad events surrounding Ben Robinson, the young Ulster schoolboy rugby player. It's also important to know if a player has previously been concussed, how many times they've been concussed, if there have been any sequelae, or if they've been concussed in the last year. We now know, of course, that a history of migraine is significant, a history of defective eye movements, such as squint, strabismus, a history of inner ear problems, such as motion sickness. They also may be significant. Something that's becoming more common, particularly with underage players now, is a lot of learning difficulties are being diagnosed more frequently, particularly attention deficit hyperactivity disorder, and this predisposes to concussion. We've known for quite some time, of course, that players that have a history of anxiety or depression are more vulnerable. So back to the sideline and witnessing the impact. I mean, there certainly are times when you see the impact and you say, I don't care what happens now, this player is concussed, this player is coming off. Certainly if you have a high velocity impact, everybody talked about Lee Keegan and Owen Cadigan already today. That's one example. There are many more, and I'll give you some more. But a player who's blindsided or double-teamed, all of this can be very informative. The way a player falls, if a player is concussed, they will usually fall, but that's not inevitable. Sometimes they won't fall to the ground. Less than 10% of them lose consciousness. Convulsions or tonic posturing are very rare, but they do occur. From a doctor's perspective, the way the player falls, the way they impact the ground, and their subsequent progress can be very instructive, particularly if there is any concern about a neck injury. So the system then should, as far as I'm concerned, the system should follow the internationally accepted ATLS protocol. The first task for the doctor when he arrives at the injured player is to make sure that the airway is patent and that the player is breathing properly. I've encountered all kinds of problems such as swallowed tongues, displaced mouth guards, an oropharynx full of vomit, and even a fractured jaw. And if a player is unconscious, then I will immediately initiate and supervise the ATLS protocol for immobilization, for transfer, and for initial resuscitation. Now, I didn't see I don't know a lot about soccer, I have to admit, and I didn't see the actual game the other night. But from what I've heard, the player was moved by another player. One of the big bugbears I have in GEA is that sometimes when a player falls, somebody else will try to lift them from the opposite team. This should not happen, because if a player should not be moved until the cervical spine is stabilized. And certainly where you have paramedics and doctors and everybody else. So this is an educational issue for players as well. But I want to make that point very clearly. So having cleared the airway, having established that the player is not unconscious, the next part of it is to make sure that the neck is okay. In other words, that the player hasn't sustained a neck injury that if they're moved inappropriately, they could frankly finish up paralyzed. That can be done again by an experienced doctor by palpating the neck and asking leading questions about pain in the neck, stingers in the upper limbs, pins and needles in the upper limbs, in the lower limbs, ability to move the forelimbs. So once I have established that the player's conscious level is satisfactory, their airway is okay, their neck is okay, and that there is no evidence of a deep cavity injury to their abdomen or chest, I get them on their knees so that I can inspect their eyes and look at their eye movements. This also gives me an opportunity to ask them questions about headache, about dizziness, about double vision, about nausea, and sometimes photophobia. The eyes and the facial expression, they have a characteristic appearance which is very difficult to articulate in concussion. In time-honored fashion, medics say that the lights are on, but nobody is home. Now that's meant to be a description, not a pejorative description. Occasionally, you will find double vision, but a lot of the time, if the technique, I see this examination performed and the technique must be perfect, otherwise you cannot draw any conclusions with regard to whether a player has double vision or impaired vision. If at this stage I'm happy, I will get the player on their feet. At this stage, I'm observing their balance, their coordination, and their spatial awareness. This gives me an opportunity to do a brief cognitive assessment. There are three things I will look for: orientation, recent memory, and concentration. Regarding orientation, it can be misleading because a player will look around them and they look at, certainly in Croke Park, and they'll know where they are straight away, or even a county ground. They will work that out. So orientation can be misleading. Maddox questions, but they must be adapted to the player. These test recent memory. My practice would be to adapt them to the Donegal game plan of that day, and I know very quickly what their recent memory is like. With regard to concentration, that test on the pitch, asking a player to repeat words or sentences or numbers backwards, well, I wouldn't like to tell you what the usual response would be, but it's not very productive. At that stage, if I'm happy, I let the player return to play. But I'm still watching the player, because if you know your player, you'll pick up subtle nuances in their gait, their balance, their coordination, their understanding of what's happening around them, their adherence to the game plan, and their decision making. And if I have any doubts at this stage, I will revisit and I'll take that player off. So, the rehabilitation of concussion begins in the dressing room, because most players require reassurance. The management of concussion, and we put a lot of emphasis on this, and I'm convinced the results that we get are down to meticulous attention to detail from the word go. We don't have the resources that our friends in Pittsburgh have, but we approach it in slightly different ways. So the management in the first 24 hours is an exercise in common sense. A player should not be left alone, and I'll come back to the reasons for that. That'll become apparent. They shouldn't drive. Again, if you're managing Donegal lads, a lot of them will be heading back to Dublin that night or whatever. They should not drive. They shouldn't drink alcohol. They shouldn't take any medication apart from what is advised by a doctor. And for the first 24 hours, I advise them very strongly to minimize their use of mobile phones and information technology in general. I agree with Mickey Collins that if you advise one of these young lads not to use mobile phones or information technology for a few weeks at a time, that's it, that's not going to happen. But you do advise them to be sensible about the way to use it, and that if they're getting tired or getting headaches or anything like that, just to back off. I said it's important not to leave a player on their own. The big red flag here is that an extradural hematoma, which is a bleed on the surface of the brain, can be confused with concussion. Both injuries occur as a result of a head knock. Both may have a brief loss of consciousness, and both would appear to recover satisfactorily. The problem with a bleed in the brain is that will continue, and that will require emergency surgery. You don't want a situation where you're in a peripheral hospital, as I've been, where it's necessary to do boreholes and remove these clots. This operation actually is greatly exaggerated. It's not brain surgery. It's removing taking away a piece of bone and removing clot, and it's quite a gratifying operation to do. But you don't want to get into that situation. So you advise the player that in the event that their symptoms deteriorate, they need to report that, or depending on where they are, go to the nearest emergency department, because you want to get them to a neurosurgery centre. This is an example of somebody, just to tell you, it doesn't take a lot of bleeding on the brain to cause a fatal outcome. This is somebody, not a GAA player, who died as a result of a blood clot the size of a golf ball. So after we get over the first 24 hours, common sense again is very, very important. It's important to optimize diet and hydration, and I won't go into that, but I will mention a little bit about sleep. In my experience, almost inevitably, the players that I've treated from all ages, from 12 up, have problems sleeping. They wake up, they can't get to sleep, they get agitated because they can't get to sleep, they're exhausted the next day, and they try to sleep the next day. For what I think works well is to try to restore their circadian rhythm. In other words, their normal 24-hour body clock. You get them to go to bed at the same time, you get them to get up at the same time, and you get them to persist until they can get 8-10 hours sleep a night. What you advise them strongly against is sleeping during the day. You also try, if at all possible, to avoid pharmacological intervention. Physical activity, there has been incredible work done in Pittsburgh, and obviously there are figures with regard to getting the player active as quickly as possible. They cannot be disputed. Now, Mickey was very hard on the international consensus people, but in fairness to them, and I'm not an apologist for them, the guidelines are 4 years out of date, and some of them are pretty inaccurate as well, and there's no doubt about it. One of the things I learned, and one of my practices I changed from my time with Mickey, was I now get a player, depending on the symptoms they have, if their symptoms allow, I get them on a stationary bike, walking or jogging up at 50 to 75% of their heart rate. And I'm absolutely convinced this is beneficial and this is the way to go. Every concussed player that I have treated is stressed. They're stressed because they can't sleep, which we just talked about. They're stressed because they're afraid they're going to lose their place in the team. They're stressed because they're worried about keeping their job, or they're not able to keep up at work, or they're stressed because they have exams coming up and they're worried about what Professor Mina might be saying to them in DCU. So it's the counsel of perfection to avoid stress, but again, a lot of this requires reassurance. We would be very strict about our return to play protocols in the GAA. There's absolutely no doubt now that a player who is diagnosed appropriately and managed appropriately and who go through a supervised return to play protocol, they do not have any increased risk of becoming concussed again, and they certainly don't have any risk of these horrific long-term complications of chronic traumatic encephalopathy, Parkinson's, or Alzheimer's, and it's very important to reassure them with regard to that. So let me talk to you about a few players that I have treated. Everything I'm about to say about these players is in the public domain. I'm not talking about anything that's not out there. This was the McKenna Cup, January 2014 against Tyrone. And Martin O'Reilly, right in front of the dugout, got an elbow in the side of the head, completely accidentally. But before he had hit the ground, I decided this is a concussion and Martin O'Reilly is coming off. When I examined him, or when it didn't take a lot of examination, you can see clearly that he's got an impact to this area. This is called, it's called the temple colloquially. In surgery, we call it terion, which is the thinnest area of the bone, the most vulnerable area of the bone, the area which marks the middle meningeal artery, which bleeds in these circumstances. So my initial concern here was that he could finish up having a hemorrhage on the brain. So I had the luxury at that time of being able to admit him to hospital and take care of him in hospital, which I did. He didn't actually need a CAT scan, but just if a player gets a blow to this particular area, is unconscious, they need to be admitted to hospital for a 24-hour period of observation. This was a high-velocity injury as well. The Ulster final 2013, Mark McHugh was in a high-velocity collision with a Monaghan player, again completely accidental. Again, before I left the sideline, I had made a decision that he was concussed. My main concern was because the way he fell, his head and neck actually bounced off the ground, and my initial concern was for his cervical spine. So I took quite a considerable period of time to assess him and to make sure he was okay. I pay tribute to the referees. I have to say the referees in the GAA are absolutely brilliant to work with. I think it's become almost a partnership. If there's a concern about concussion, the referee will tell you to take as long as you like and make sure you get this right. I think it was David Coldrick on that particular day. We were so long that Jim McGuinness, who never left the touchline, came out to see what was happening. And Jim's question was, well, can we take him off and put him back on again? I said, no, he's going to come off and he's going to stay off. And I'd also pay tribute to Jim McGuinness and to Rory Gallagher, the two managers I've worked with. They have never once tried to influence the medical decision. In fact, they've been very supportive, even though I'm sure it's been counterintuitive at times. As it happened, Mark had not alone a concussion, he had a ruptured eardrum and he had a torn quad muscle. But again, after going through return to play protocol, he's had no subsequent problems. This was in the National League against Dublin under lights last March. And somebody talked about being able to see from the sideline what's happening the whole time. As it happened, somebody just stood in front of me. There was a high ball being kicked into the Donegal goalmouth, and I didn't actually see what happened. The next thing I saw, when the smoke cleared, the ball was in the net, and Paul Durkin, the goalie, who was a very big man, was on his knees. And Dermot, a very excellent physio, thought he'd injured, it was a musculoskeletal injury, so he went in to have a look at him. And he called me in because he noticed that he had a laceration to his ear. And when I went in, he just didn't look right. And I went through the whole protocol. As will happen with players in a situation like that, the Dublin lads obviously thought, well, Donegal have just conceded a goal, and they're killing time, so they were advising myself and Dermot and the referee to get on with things. Paul went through all the assessments until I stood him up, and whatever way the lights come down off the Davin stand, he just winced. And I asked him to look at the lights again, and there was, as far as I was concerned, there was definite photophobia. So it's a difficult one, a clinical decision, because was he just been blinded or dazed by the lights? But I was happy. I took him off to suture his ear, and as soon as he got up off the gurney in Croke Park, in the medical room, he got very, very dizzy. And as Anthony Contas and Michael have pointed out, this is quite a significant symptom at that stage, because it means that rehabilitation will take longer and return to play will take longer. And it actually did, but I didn't know why at that stage. I've since been educated by our friends in Pittsburgh. Sometimes, and I'm coming to the end now, it can be quite subtle as well. Ryan Bradley has the distinction, I suppose, if you call it that, of been concussed playing against Down in the Ulster final in 2012 and playing against Down in the Ulster semi-final in 2013. In the first concussion, Ryan is he's a very big man. He's over 6'2". He was weighing in over 15 stone, and his body fat at the time was about 10%. And he was in collision with a much smaller Down player, and everything seemed fine. But a couple of minutes later, he went down on one knee, and he just waved me in. So I went in, and he said he was dizzy. But before I could do anything, he jumped up, and he ran back, and he caught a kick out, and he sold it at about 30 yards and kicked the ball over the bar. And he went down again. And this time I went in fairly quickly, and he said he could see 3 sets of goalposts. So I said, well, Ryan, that's that. No further decision to be made here. And he went through a protocol, and he had no difficulties after that. The following year, he was Dr. Charlie McManus, a good friend of mine, an excellent doctor, was doing duty at the game. And I didn't see the incident, but Ryan got in a tangle in the air and came down very heavily and hit the back of his head and neck. And Charlie was very, very concerned for his welfare, but got him got him back on his feet. I actually finished up that day having both Ryan and Frank McGlenn, 2 people, same day, same half, in hospital. So sometimes concussion can be very, very clear-cut. Sometimes it can be very subtle and insidious. So where does all this leave us this morning? I have to take you back down to earth again after hearing our experts from Pittsburgh, and it's a resource issue really for us. If I want somebody to be seen by a neurologist, it's going to take me 6 months. I don't know any neuropsychologist in Ireland by name. I know 1 or 2 by reputation. And I would say about our chartered physiotherapists, they're absolutely first class. They're absolutely first class. But I don't know any chartered physiotherapist who's been trained in vestibular, ocular, and motion therapy. Now, that's not to say that they can't be trained or upskill themselves very quickly and very easily, and I'm sure they can. And I would hope that will be our next phase with Pittsburgh. But I do want to make the point as well, because parents will sometimes be anxious that, well, if my child or my whoever hasn't been seen by all of these people, well, then they've been neglected. And I want to send out this message very, very clearly. In my experience of dealing with these players, 90% of players that are taken off the pitch immediately and managed appropriately recover very quickly, and they have no further sequelae. And this can be managed by the excellent network of team doctors we have, by general practitioners who have an interest in this, or by a sports medicine doctor. So that leaves us with 10% of players who have a more protracted course, who have more complicated symptoms, who have symptoms from 2 or 3 of the domains that I spoke about. And they clearly need a multidisciplinary team, ideally with a neurologist, with a psychologist, and with a physiotherapist with all the training. But there's clearly logistical difficulties in accessing all of these people. So I'll leave you with the thought that concussion is not a serious problem for the GAA, because the GAA take concussion very seriously. But the caveat is, of course, that there's no room for complacency. Thank you very much.
Yeah, does anybody have any questions on that? Yeah, sure.
I was just wondering about the links between the repeated concussions. I thought I heard you mention that if the concussion is treated properly and managed, that there's no long-term implications.
I'd be interested to see what Dr. Collins and Contis have to say about this as well. But from my reviewing the literature, if a player is treated appropriately, then there isn't a long-term risk. It's in the players who haven't been treated appropriately that are at more risk of developing a second concussion. And frankly, nobody knows who is going to get the long-term consequences, the long-term problems such as chronic traumatic encephalopathy, Alzheimer's, or Parkinson's.
What about the unfortunate 10%?
Now you're back to healthcare and logistics in Ireland. Obviously, at the moment, there are 2 public clinics, one in Cork and one in Dublin, both run by Professor Mick Malloy, who's given sterling service to this. There's a private clinic, which is an excellent clinic, in the sports clinic. It's superb. I've seen tremendous results, players that have been treated there. Neve has started her clinic in Cork. But after that, then, for me, it requires making a lot of phone calls and accessing the right people. But it's not just a simple process of writing a letter and referring somebody.
Is seeing the black circles a definite sign you have concussion?
If somebody said to me they were seeing black circles, I would take them off.
Well, I saw them twice in my playing days. I finished both matches.
And you're still here.
Still alive.
That's good. But I wouldn't be recommending that for young players, no.
All right.
Thanks very much.
Good stuff. Dr. Kevin Moran, everybody.